So I think welcome everybody. Today, I think we have one of our mentors who is giving us a topic on neuropelviology. And I think it's also quite opportunistic because he has just recently come from Europe and he should be fresh on the topic. And I think over to you, Dr. Vuma.
Thank you, Dr. Shawa. Good evening, everyone. I'm really humbled that I'm able to share some of the things we went through, but I got a problem that I didn't know how much is too much and how much is enough, because I remember the original intention of these meetings was that once you have left the cave, you don't want to be professors of cesarean sections, I remember. You want to have something that you can take to change your practices, something that you can take and improve the way you teach the juniors even under you. So basically to just share the insights, because obviously for me, I've done a lot of reading about neuropelviology. This was just the second exam. So I just thought maybe I'll just share and highlight a few issues, have one or two cases that I can discuss that I had here, just to highlight the importance of having a neuropelviological exam view. So basically on the path to mastery, to being a master, you start as an apprentice where you know nothing, you watch others, you're an intern, you can make mistakes, but the master or your consultant takes they take the credit for your work and the credit for your mistakes. Then I think for all of you, we have shown passion and dedication to be on this path. You definitely are special because you have decided to learn more than doing cesarean section. So you have basically launched your career, you now are becoming independent experts. You now start taking responsibility for your work. The mistakes are yours and you have to deal with the consequences of those mistakes. But in that process, you keep on developing skills, developing more insight. And then the final stage is then you become a master. Then you start teaching others. You start having your own workshops. So briefly, just the neuropelviology is basically something that has been, I think this Professor Possover, Mark Possover in Switzerland, he started on this journey about now 15 years ago. And basically his training was a vascular surgeon, and then he was also an orthopedic surgeon, and then, neurosurgeon, sorry. Then eventually became a gynecologist. So he used all that information to basically, try and develop this new field, because the nerves in the pelvis can only be accessed through laparoscopy. The neurosurgeons cannot access the pelvis, the bony pelvis, because it's protected by the thing. But with the advent of laparoscopy, the magnification, the view, you could actually access the intrapelvic portion and all the pathology that is in the pelvis, which is impacting on the nerves. So that's briefly, roughly my outline that I was thinking about. I think I'll just go through some of the things. So one of the things that when we come away from this thing was, yes, everyone can do laparoscopy. Everyone can dissect nerves. That's the small part of it. But you should know that is the indication correct. Are you dissecting the right nerve? So you must have pre-operatively made the correct diagnosis to say what is the pathology, where is the pathology, and what type of pathology it is. So the first thing starts with, obviously, when you first went to medical school, but this is something that obviously is being neglected. The first thing is, when the patient comes in, you should go to the reception area, greet the patient, look at their eyes, because one of the tricks he asked after we had all greeted him, he asked, "What are the color of my eyes?" So you must look, but you must actually see deeply. So you should look at the color of your eyes. You see, is there any redness? Is there anything? So you should actually see the patient in totality. Are they sweating? You shake their hand. Is it cold, clammy? Is it sweating? Or is it dry? You look at their lips. Are the lips dry or cracking? And you look at their armpits. Are they sweating? And are they having any tremors when you look at them? Then you ask them to walk in front of you to, as you escort them to your room. You look at their gait. Are they having a foot drop? Are they having a Trendelenburg gait? And obviously, you look at their calves. Obviously, they're not putting on the trousers, I suppose. Is one smaller than the other? Is there myotrophy of one? And then eventually, when you look at them, when they undress them, then look at the size of the buttocks. Is there one buttock that is smaller than the other? And then one of the big things is that you bring them into your rooms and you ask them to sit. So all this, you're just getting information before you have even spoken to the patient. You are getting to know the patient before you ask them. You ask them to sit. If they can't sit, you see, can they sit on both buttocks? Or are they uncomfortable on one buttock? Or do they prefer to stand? Because therein lies your diagnosis that there is a nerve problem. So then once you have started the formalities, you should ask them, how you can assist, how you can help them. And then the thing is, listen to what they are saying. What are they talking about? What is it that they really want you to help them with? Because most likely, you are not the first doctor that has come to see. They've probably been to so many other doctors, but they are all plagued with the same problem. They talk, but they hardly listen. Try to clarify the issues. Like, for example, in gynae, most of their consultations are based on pain. Where is the pain? What type of pain is it? Is it shooting, stabbing, or is it vague down? Is it well localized? Does it radiate down the front of the leg? Does it radiate the back of the leg? Or does it radiate upwards? Can they point with one finger where the pain is? What positions, like sitting, does it make it worse? Does standing make it worse? When they lie down, how does that pain become? Or is the pain worse as the day progresses? Or is the pain worse premenstrually or during the period? And then you then ask out of 10, visual analog scale, how many times out of 10, how bad is the pain? And you record that, the type of pain they're saying. So you have to decide now, this somatic pain or this autonomic nervous system. So when you look at it, you ask also about the bladder, the urine, the frequency. Do they have to push the abdominal wall to empty the urine? They always have to rush back to the toilet with incomplete emptying. Is there any agency? Is there any frequency? And then polyuria is when you pass urine more than 8 times per day. So that's a big problem. And then when they cough, laugh, do they have incontinence? Or can they not empty the bladder at all? And then you should also then ask, I think one of the things that I don't know whether culturally it's always difficult to ask about incontinence, anal incontinence. Are they incontinent to flatus, to stool, or do they have complete voiding? Do they have any pain during the period when they pass stools? Or do they have like sensation of stones in the rectum? All those are obviously working towards a neurophysiological diagnosis. So you have to get the history from the patient. And then the other thing which is also there is For example, you have to go into the obstetric history. How big were their babies? How long did they take to push? So once the baby is more than 4 kg, there's high risk of pudendal nerve damage. So how long did it take for them to push? So more than 20 minutes is also a risk factor. If they have to have vacuum or forceps extraction, and then did they have an ischiorectal abscess? All those things you have to ask from them. Did they have an episiotomy? And then you localize where the like in terms of the pain, they had radiation. Do they have superficial dyspareunia? Is it superficial or is it deep? Or does it occur post intercourse? And then the other thing is obviously you have to ask about their surgical history. Did the patient pain start immediately after the operation, or did pain start years after when they got into menopause? Because with the hypoestrogenic stage, you then get fibrosis and then the pain, it becomes evident. So the question is, they have any laparoscopy, then you worry about fibrosis. Do they have anything like, for example, these meshes? You talk about the genitofemoral nerve. Do they have laparoscopic trocars? You put them two lateral to the anterior iliac spine, then injure the, or even you did appendectomy, the ilioinguinal and iliohypoglossal nerves. So just from the history, you have to go into detailed surgical history. And then the question is, when did it start and what makes it worse? And then you then go to your examination. But this is just some of the nerves that the somatic nervous system that you find in the thing. There are others that I haven't put in there that are more sensory, but we can carry on. So that's basically the anatomical organization of your central nervous system. The central nervous system, the peripheral nervous system, and then you then have the autonomic nervous system, and then this is basically basically the patient has had surgery, and then they have pain post-surgery. So is it a neuropraxia, where it's a temporary conduction defect which will recover, or is it completely cut? In which case, the pain, they can pinpoint this an autonomic, somatic nerve exactly where the pain is. And the autonomic nervous system, the sympathetic nervous system, is basically from your, I think, 31 paired nerves that actually leave the spinal cord. So there's the sympathetic trunk, which runs in there. And then next to that is then the prevertebral sympathetic ganglia, which are along the anterior surface of the aorta. So you've got your celiac ganglion, superior mesenteric, inferior mesenteric, and below that, the superior hypogastric plexus. And then it then divides to get into the pelvis as the right and left hypogastric nerves, which will then go further to join to make the inferior hypogastric plexus with the pelvic spastic nerves and the sacral sympathetic nerves that join to form the inferior hypogastric plexus. So basically, then there's the parasympathetic innervation, where you find the heart, the lungs, the stomach, and the small intestine, and up to the proximal, up to this transverse colon, the vagus nerve, the parasympathetic, the cranial parasympathetic supplies up to there. From the top, from the descending colon up to the rectum, is from the pelvic splanchnic nerves. That's where the innervation. So the pelvic splanchnic nerves also then, how do they get there? They actually then go along the fascia and along any of the nerves to get to supply the sigmoid and the rectum all the way to the anus. And then those are the
Hello, am I the only one who's lost audio? We've also lost audio.
Dr. Buma, can you check your mic? We can't hear you.
Dr. Buma, we can't hear you. Dr. Buma, can you hear us?
Hi, how are you? Why? Yes, it's scaring me. Why should I be the one searching it out?
It looks like
I read along with the
Dr. Chikosi. Dr. Chikosi.
Hello? Just give me a second. Hello?
Is anyone able to call Dr. Buma? I think he just lost connection.
Just give me a second. There's something else. Hi, someone is trying to speak to me. I listen to call someone.
Hello.
Jesus.
Yes,
Hello?
we had lost you, Dr. Buma.
Yo, no, now I don't know where you lost me. Can you see the
Someone
slides
scream my
now?
name.
We still can't see your slide.
Okay. They say only hosts can share this meeting.
My bad. Let me just give you co-host rights again.
Okay.
Dr. Chikosi, we could hear you in the background. That's why we were trying to make you aware of the situation, but I've been trying to mute you. I've given you co-host rights, Dr. Buma. You can try sharing again like we did earlier. Dr. Buma. Is it my network now?
No, Chipo, we all can't hear him, but we can hear you.
Okay, Dr. Buma, you can try to share your slides now. Thank you.
Okay. Can you see the slides?
Yes, but I think we were a few slides
Back.
that, yes. We first lost your audio.
You lost the audio.
No, we didn't hear audio.
So which part did I get?
This slide. This slide.
Which slide?
Yes.
Can I go on this one?
Yes, please.
Oh, okay. So generally, there's always a balance between the sympathetic and parasympathetic innervation. And apparently, we basically designed to have the sympathetic system going, otherwise we'll all die, because the parasympathetic is not good for your health. So anyway, the whole thing that I was talking about was obviously the vagus nerve supplies the heart, the lungs, the stomach, small intestine, and up to the transverse colon. And the distal part is supplied by the S2, 3, and 4 pelvic splanchnic nerves, which will then supply the sigmoid and the rectum and the anus, and then the external genitalia. And then the parasympathetic, the pelvic splanchnic nerves are necessary for the rectal function. So it's basically for evacuation of the rectum and of the bladder. The sympathetic system is therefore continence, so that you keep it actually calms down the bladder. So the sympathetic system will supply your internal urethral sphincter and your internal anal sphincter, whilst the parasympathetic will supply the external urethral sphincter and external anal sphincter through the predental nerve. There's what is called the onychus nucleus, onychus nucleus, yeah, something like that. So these were some of the conditions I wanted to quickly go through. Some of the situation. I'll go back, but these are the things that I thought maybe I can share with you. Maybe you can come across the patients after I've done a thorough history, and then you then look at the nerves as they are shown there, your ilioinguinal, your genitofemoral nerves, or the genital branch, which will go towards the mons pubis, then the lateral cutaneous nerve that goes on the lateral side, which gets affected in patients who are pregnant when all we've got a huge panniculus in the tummy, then tends to obstruct that lateral cutaneous nerve. So it's a sensory nerve. Then your femoral nerve is also motor, it's got sensory also effect. The obturator nerve also obturator internus muscle, but then so the thigh adductors, but it's also got a motor function. So then we'll go through the superior gluteal. So once you know the innervation, then when you look at the symptoms that the patient is presenting with, you'll be able to then narrow down to say, where do you think the pathology is? And for example, this is a case where in endometriosis, deep infiltrating endometriosis, you remember the type 2 nodule is the more medial nodule. So it will definitely be involved with the S3 mainly, but also S2, S3. So you can actually see then you have problems with bladder control, either hypersensitivity, or they can't completely empty their bladder or their rectum. So in your history, you should have actually then asked about that. You completely empty or you don't empty your bladder. So that will be the one case. And also there's, this is the other picture where, just to put in perspective, where the aorta, inferior vena cava, so inferior, the mesenteric plexus, superior hypoglossal plexus, and then it divides into the right and left hypoglossal nerves. So this is a retrorectal dissection. So if you go where the right, where there's a star there, that's where your sacral promontory is. So if you started the sacral promontory, you'll be able to dissect and push the rectum forward. At that level, you should also be able to go laterally. You'll be able to see your sacral nerve roots and your lumbosacral trunk. They also go over the sacral promontory and get into the pelvis. But normally to approach that, you don't use this method because there's a lot of venous, lot of veins in this area, so they will tend to bleed a lot. So you rather come more from the lateral approach, the lumbo-aortic approach. So, for example, this is the one I was discussing earlier on, where the patient with an outward canal syndrome would have we have to ask about the history. The patient definitely will not be able to sit. She feels better if she stands. And because it's higher up, so the pain radiates to the front, it means the lumbar plexus is involved. If pain radiates to the back of the leg, then it actually is the sacral. So there's no radiation of that pain because the nerve is actually in the intrapelvic portion of the pudendal nerve. And then for example, these are some of the interventions where you should be able to look. A patient presents with valvodynia, with posterior valvodynia. So you see the three branches, the three branches of the three branches of the pudendal nerve, the dorsal nerve of the clitoris. Then there is the perineal, which is the middle branch, and the inferior rectal branch, which is what then supplies your external anal sphincter. So basically, depending on where the pain is, if there's any episiotomy, you will be able to have point tenderness, and she will actually be tell you where the problem is based on that just by looking. So if you look at the interventions, then if you have a Zaren section, then we have burning pain. It's either maybe a neuroma or a neuropraxia because you were using retractors when you did a cesarean section. So your genitofemoral area, ilioinguinal, it's more of that valvodynia, which is the upper part of the vulva and the suprapubic area. And if those who do Makao fixation, you know, then there's also a danger of using injury with sacral nerve roots S2, S3, and then the pudendal nerve, and also with the sling. So basically from the history, you'll be able to actually identify where you see the lumbosacral trunk comes in, and as you dissect going down, you see your lumbosacral trunk, then there's S1 nerve root, the superior gluteal artery actually goes through between S1 and S2. So that's how you see where they are, and then the sacrospinous ligament. So like for example, in the Lion procedure, where for a person to stand and walk, they need the femoral nerve. So you will then put an electrode on the sciatic nerve, on the femoral nerve, sorry, so that they can flex their knee. And then you then put another one so that they can stabilize with the back muscles. You put an electrode on the sciatic nerve root. You just coil it around. Like patients with bladder incontinence, urinary incontinence, bladder incontinence, overactive bladder, rectal incontinence, or specifically in spinal cord injured patients, where it's actually they are spastic or an incomplete, which is where the lesion is above 2 T6. You then will be able to actually put an electrode on the pudendal nerve, and then you then stimulate it. So they will actually then be able to control and empty their bladder and also empty their rectum. So this is one of the things that when you do a laparoscopy, basically this is just on the right side. You can see the psoas muscle. You see the nerves directly. If we are in a thin patient, you'll be able to see these nerves. So it will be your face will be your hypogastric, then ilioinguinal, then lateral femoral cutaneous nerve, and just on the lateral aspect of the psoas muscle, just underneath there is the femoral nerve. So you dissect that, and then on the psoas muscle, then is where you find the genitofemoral nerve. If you go deeper between the psoas muscle, this is the external iliac artery. If you go between the psoas muscle and the external iliac artery and vein, you dissect and separate between the two. The first nerve you hit is you'll find is the obturator nerve. And deeper than that, about 2 centimeters below that, you'll be able to find the sciatic nerve, which will be, this is the level. So this is just right at the top. Obturator nerve has been pushed to the left, and the lumbosacral trunk, and then you see the superior gluteal nerve, then the inferior gluteal nerve, and then sciatic and pudendal. So basically, this is where, if you have done your history examination, you'll be able to find where is, like, for example, they've found isolated sciatic nerve endometriosis. I've had a patient that also presented with that. But because of the history, you know exactly where to dissect based on that. And also the other thing that is also with this neuropelviology, there are also tumors of the pelvic nerves where you get a schwannoma, neurofibroma, or malignant schwannomas. So that you could also be able to, for example, the schwannomas, you'll be able to access it, and then actually comes like a jelly-filled thing. Now, the other thing that I wanted to share with you was also things like, for example, this called Fowler syndrome. Is basically urinary retention in young women, usually in 20, 30 years. It can happen post-operatively, or it can happen after a normal delivery. And it was discovered by, I think, Professor Fowler in 1985. And basically, it's the spasm, sorry, of the external urethral sphincter. And it's associated with because in about 50% of patients, no one really knows the cause. And the question is, what is the treatment? Some people speak of sacral nerve stimulation from the back, where the neurosurgeons can put an electrode and maybe at 5 hertz or so stimulate the nerve, and then maybe that can, but generally in most cases actually resolve spontaneously. The other thing that is also there is where when you ask for the history from the patient has been to the general surgeon, and then this is the picture you find. They've just put in a mesh, an inguinal mesh, and you find nerve entrapment. Before they used to say you should remove the mesh, but basically it causes more fibrosis. So you should actually cut around the mesh where the nerve is involved, and then leave the mesh there. You don't have to remove it because it creates more fibrosis. And the other thing I wanted to share with you was the, I had a patient that I wanted to discuss with you. I had a patient, 34-year-old, para 1, grav 2. She had, I think she was about 10. She had a T4 motor vehicle accident and a T4 lesion. So she's a paraplegic, incomplete paraplegia. So she's spastic. So basically her legs are always having tremors. And so in the first pregnancy, there was no problem. The pregnancy went well because the pelvis had never developed. We thought to do we did a cesarean section, spinal C-section, no problem. In this current pregnancy, she presented this year, and I think in the 3rd trimester, she started having severe hypertension, and the blood pressure was going over 270, the systolic even over 170. We couldn't figure out what the problem was. We tried to throw almost everything at her, but the blood pressure would not resolve. But one of the things that was there was that we found she had a UTI, and then she had a preterm labor. We delivered her at 32 weeks, but her symptoms got worse, and the blood pressure never settled, and she went to a tertiary institution. So when I was over there, then I tried to find out what the problem was, and then it was a thing called autonomic dysreflexia. So all patients with spinal lesions above T6 have sympathetic. So any cutaneous stimulation, a full bladder, a UTI, a full rectum, even sex, like in a case she was pregnant and she was having contractions, it will actually cause the upper part of above the lesion. There's a sympathetic system actually cause overactive, and the parasympathetic, which is supposed to lower the blood pressure, cannot. So they've got vasodilation above the lesion. Below, they've got it's cold, it's wet, and they've got sympathetic dysreflexia. So the treatment basically is either you press both eyeballs, to stimulate the, if you saw on the other picture, your vagus nerve. That should actually reduce. So they can have these attacks about up to 40 times a day. And the case in this case, the most specific treatment is an alpha blocker. That is the one that will be thing, but you should be able to tell them what to do in a response, because most of them die early because of intracerebral hypertension, because of the bleeding. So that's one of the things that I got an answer to. And then the other things that I saw were this loss-Pennis syndrome. I had never heard about it, but all this is obviously related to the autonomic nervous system. And there's also another thing, postural, what's called POTS, postural orthostatic tachycardia syndrome. And so basically when you do your examination, and like when you're looking at the patient, you'll be able to see the temperature. And also the other thing that I also failed to mention was that during the examination, apparently you must have a laser thermometer to actually find if there's any temperature differences in both limbs. If there's a temperature difference, then it means the other side, there's actually vasodilatation and vasoconstriction on the other side. So the side with the higher temperature is the side of the lesion that you are looking at. So there's also then this one where they were making us read about this difference between your cord equina, which is indeed the spinal cord ends at L1, L2, and the nerves eventually come further down. And the chorda medullaris is the last part of the spinal cord. So that is one of the things that you also could also learn about that. And then which one was this one? Okay, and then the other one was also I found very interesting, was the anal wink reflex, and or the anal wink or the bulbo cavernosus reflex. So basically you can either, so basically in the patient with a spinal cord injury, they go into a phase of spinal shock. So if there's an upper motor neuron lesion is above T6, what happens is sacral reflex is preserved. So after 4 to 6 months, you can actually determine which patients are going to recover whatever, because if the sacral reflex is present, so you can either do a pinprick around the anus, and then you should see the muscle contracting. Then it means that the sacral reflex is intact. Or you can gently tap on either side of the clitoris. But unfortunately, the problem is that you have to basically get consent for that. And in a man, you also hold that, and then that should also elicit that reflex. So basically, the main difference was then in deciding whether the site of the lesion, what is then causing it? Is it visceral pain? Is it somatic pain? If it's somatic, so which nerves are involved in the pelvis? Where? And then what's probably pathology? Is it endometriosis? Because invariably in most patients where, if you listen to what they are saying, they always have these laparoscopies which are negative. But because this lesion is deeper than the superficial, because I mean, most of these cases with isolated sciatic nerve endometriosis, they had several laparoscopies which were turned negative, which was reported as negative, but meanwhile they had actually pathology. So there's also another thing which is also called neurovascular conflict, where you get the different variations in the nerves. Usually the nerve can be trapped between two vessels and maybe the bone at the back. For example, the superior gluteal nerve, vein and artery may cross. Normally they should cross behind the sciatic nerve, but sometimes they cross above, and then that positive feeling. So when you get your history, the patient will tell you the patient is worse when I stand up, but it's better when I lie down. And also it could actually be exacerbated around the time of your period, So which is also the same, but the difference would be the way they describe the pain. So patients who have had also operations would have also fibrosis as a cause, and then the other one would be the tumors. And I wasn't sure how much else to go into, but I thought maybe just to say there is relevance in knowing the pelvic uroanatomy, that it is actually clinical relevance, it has clinical implications. And for example, I had a patient who was referred, actually was self-referral from Uganda, and then from their history, the history was there. She said, my pain in my leg is getting worse. It's going to the back up to the big toe, back of the leg all the way to the big toe. And progressively, it's worse during her period. She can hardly walk during their period. And now she was dragging a big toe as she was walking. She couldn't. So already you already knew where the lesion was. It was the sciatic nerve. So the question is, which dermatomes would the pain be? If it's S1, then it will be at the close to the nerve roots as the roots exit the thing. If it's lower down, then you will have bladder involvement, that S2, S3, then you also have some bladder dysfunction. And the other thing that is also important is that obviously all the operations that we do, for example, hysterectomies, there's obviously a reorganization of the pelvic veins there. So you actually end up getting pelvic varicosities, which can then worsen the pain that the patient having, because the nerves are getting irritated by the nerves, by the varicose veins. And also the other thing is the location of the inferior hypoglossal plexus is prone to injury during a hysterectomy. And the one last point was also the issue about I don't know how many are doing veteran hysterectomy in Zimbabwe, but I asked a senior colleague the other time and asked, okay, how many patients have bladder and bowel dysfunction after your veteran hysterectomy? And they said none. Then it's either it was incomplete surgery or they never asked the patients. Because obviously if you don't dissect out, you keep the inferior hypoglossal plexus lateral, then you will obviously injure the bladder branch of the inferior hypoglossal plexus or the rectal branch. So the question that is there is that obviously you then need to ask, like the surgery, what type of surgery he had and what else could be done. And then also like patients who have had radiotherapy, you also need to ask about bladder dysfunction, which could actually be related to the pelvic autonomic nervous system. I thank you. Hello.
Thank you, Dr.
Thank you
Vuma.
very much.
Thank you, Dr. Vuma. Do we have any questions, comments? Yes, Enesia.
Thank you, Dr. Vuma, for your presentation. Just to ask on the last statement, when Vitam's hysterectomy is done, is the bladder injury or the bladder dysfunction you're describing, is it temporary or is it a permanent side effect of injury to this nerve?
In most cases, it takes long, if ever it recovers. It depends how radical, because like, for example, the tumor is starting from there and goes to the paracarpium and parametrium, extend going outwards. So it just depends. If you don't like dissect it out, yes, it can actually be permanent. Those patients will not be able to, because you are getting the sympathetic, which is the one which actually causes the bladder to fill up. And then you are also getting the parasympathetic nerve. So the patient won't be able to void. And also the other thing that they also mentioned is that all of us, doctors, nurses, policemen, and I think also the soldiers, we've got mega bladders because we've basically trained our bladders. We've actually suppressed with the parasympathetic. because we are stressed, so we keep the urine longer. So the bladder, basically, we've got mega bladders as a occupational hazard.
Dr. Gwanzulu.
Thank you, Dr. Vuma, for the very interesting presentation. I was glad to hear about PERSEV. It makes some of us feel normal. I think you said he was an orthopedic surgeon, became a neurosurgeon, and then decided to become a gynecologist.
He was a vascular surgeon. Then he went and became a neurosurgeon and did not find any joy, and then became a gynecologist.
Okay.
So now all he does is neuropelviology.
Neuropelviology.
That's all he does now. So he does laparoscopy and then implants electrodes.
Nice. There's time in life to find your passion. I feel happy to know that there are people like that out there as well. But my question is really low level. You know, in the beginning, you talked about assessing the patient, and it's something that I try to do well, especially if it's something that I try to do well. But then, Dr. Vuma, yes, you can get the patient from your reception and make them walk ahead of you to assess their gait. I don't know how easy it is for my male colleagues, but then how do I assess the buttocks?
People are hilarious.
I want to hear from the male
I'm laughing.
You know, culturally, it's not supposed to be nice, but apparently that's good medicine. I don't know anything from the other colleagues. Okay, let me just share, because once I was there was a guy who had a T6 incomplete spinal cord lesion. He had been a paraplegic for the past 11 years. So he came from Germany, and the medical aid, the road accident fund there paid for the operation. So Professor Posova then brought him in to Zurich, and then he did the dissection of the femoral nerve, and he put an electrode there, and then he dissected the sciatic nerve. That's where we saw all those anatomic variations, where you found the superior gluteal vein was going over the sciatic nerve when it actually should be under. So that was a bit of a tricky situation, but unfortunately, he used the vein to compress so that he could tie the electrode to keep it in place. That was on one side. The other side was okay. So then he tunnels the thing. He puts on the right side of the umbilical cord the power, the monitor, and then they calibrate it whilst you are there. And then after that, then they start playing around with I think this is about 1 to 2 volts, and then they change the frequency. So initially the other guy, the technician, put it there, and then the leg the femoral nerve one went through the roof. The guy's foot went through the roof. So anyway, so they then went to the other side, and then they tested it and everything. And then we had the privilege of seeing the guy post-op. And it was so touching to see this guy crying, because for the first time, he saw his legs moving. And then after that, he requested to have a beer because he couldn't believe it was possible. So for me, I was actually impressed that there is this neuropelviology does have clinical applications. Dr. Shawa, anything? Yeah.
Dr. Marere, do you have something? Dr.
Good evening. Hello.
Yes,
Can you hear me?
good evening.
Okay. Hello.
Yes, I can hear you.
Okay, good evening. Thank you, Dr. Vuma, for a very stimulating talk indeed. Yeah, most of it went over our heads. But anyway, I wanted to just ask 2 things. The first one being that of our patients post C-section. 1 or 2 of them have complained about, I think you also mentioned in your talk, the funny sensation or abnormal sensation around the C-section wound. And I
Yes.
wanted you to just explain what possibly we can do to try and prevent that, and how we best counsel them on whether that sensation will come back or not, or are there ways to tell that that sensation will ever be normal, or it can actually become a permanent sort of like mild disability or abnormality.
Well, the main thing is obviously you just suspect you didn't cut anything.
Okay.
If it is just pressure compression and stretching of your ilioinguinal hypogastric or genitofemoral, then the neuropraxia will recover. So you can put them on Lyrica, which is pregabalin, and vitamin B12. Normally it should respond within 3 months. You should see a difference. But if the pain persists, then obviously you have now got where there's a transection of the nerve. So they end up with a neuroma, and then that they have that phantom limb sensation. So then you can either try, you use lidocaine or lidocaine to try and see if you can a test to infiltrate that area. And within 20 minutes or so, they should find relief. So if that is the case, then you can then either use that with Botox, which is every 6 months. Because generally, apparently, the Botox works on the neuromuscular junction. It actually blocks the release of acetylcholine, and it also causes peripheral and central desensitization. So she won't be able to remember or localize that pain. So that's one of the things that you can actually say to say, is it just a compression or has it actually been transected? In which case she ends up with a neuroma.
Neuroma. Oh, okay. Thank you for that. And then the second thing was just a question, if you could explain this phenomenon. If you had 1 or 2 patients that complain that each time they are passing urine or defecating, they lacrimate, they cry.
So crying, is parasympathetic? Is it parasympathetic?
Crying is it's parasympathetic, yes.
Parasympathetic, yeah. Because basically then you remember what we were looking at, the parasympathetic involved with voiding. So basically passing the urine, passing the stools. So basically it will be your the pudendal nerve in both issues. So the parasympathetic component of the thing. And from what they were saying, the highest concentration of nerves is in the pelvis, but they also cross-talk. Somatic, sympathetic, parasympathetic, they cross-talk, and they also cross-talk with the because you've got that pelvic parasympathetic and the cranial parasympathetic vagus nerve. So there's always apparently crosstalk between all those nerves. So it might actually be just a sympathetic stimulation, a parasympathetic stimulation, sorry.
Okay, thank you, Dr. Vuma.
Okay, and then the other thing, Dr. Marina, I wanted to find out, I was asking that, I mean, you since being in the academia, what's the incidence, I mean, when the patients have had these normal deliveries, or if you could maybe say a study to say, okay, post NVD vacuum or thing for the big babies, is there any bladder dysfunction or rectal dysfunction?
To my knowledge, I don't think there is any data that's published, because most of the patients that we see in the public sector, I think we see them, we discharge them at 6 weeks, where we just offer them the contraceptives, and then that's it, they're gone. So I don't know if, I know there's Dr. Chwanga, Dr. Ngwaru, Dr. Mgwanzura. I don't know if there's anyone who is aware, but I'm not aware of any recent publication in the past couple of years pertaining to that morbidity post delivery. And
the question that is there is it ever asked, that question at that 6 weeks? Is that question ever asked?
When we do the postnatal clinics, I doubt. I would personally say it's probably not even asked. If the patient, even things like dyspareunia later on, whatever, nobody ever really asks. Just a few patients who actually perhaps have serious problems. For example, maybe rectal, where they have like fecal incontinence or urinary incontinence. That's when they can then come back to the gynae clinic. But these are the extreme cases. But otherwise, the other symptoms, it seems like the women sort of like either think it's natural to have the sequelae post-delivery and they live on with it, except the few that have got extreme symptoms then that come up and say they've got problems, or perhaps they've got marital issues now, the husband is complaining about this incontinence, then they seek medical attention. But I think hugely a question that's not even asked.
Because what I wanted to raise is that at that meeting we had a proctologist, and then she found this very interesting because she says it's actually very common. It's just that people never seem to ask that question. Do you have incontinence? And actually suggesting that as part of our questioning, we should ask it directly. I think how you put it in Shona, it might be technically, I don't know how you ask it, but anyway. It's a bit, yeah.
Because even some of the women, when you probe them later on, they'll say things like they have flatus incontinence.
Yes.
For example, yes, they will allude, but otherwise, in a general consult, they will not actually come complaining of those things. They may just then say, "Oh, I also have this now." Later on, but otherwise, sometimes they don't even match it to being a post-delivery problem. They just then think this developed with age or whatever down the line. But I know there was a general surgeon who was looking at rectal, what do you call it when they're checking the pressures, the anal sphincter.
Yes, Tony, yes.
Pressures. Yeah, I'm just going to check with them and see what question was trying to answer and what his target population was. I think this came up, I think maybe 2 or so years ago. I'll just check and share on the group if I find anything positive.
Okay, and then one last question that I didn't put the slide here was Lavetta-Arnai syndrome, where basically the Lavetta-Arnai, they've got pain. And one of the things apparently when you do your internal examination, you can find that the Lavetta-Arnai muscle is very tense and it's painful when you touch. One of the biggest things is just if you just inject what they call needling, you can actually take that, you actually cause the rectal muscle, the Lavetta-Arnai muscle to go, the spasm to go away.
Oh.
And also they can also use, apparently a vibrator is very good for treating Lavetta-Arnai spasm, muscle spasm. And also once you have found, you have done needling, it has worked, you can also put Botox and then it actually then relaxes because it works on skeletal muscle, the Botox. That's the only thing I wanted to share.
So Dr. Vuma, in that same line then, would that explain part of the treatment for, or is it something totally different for vaginismus? How does this?
Yes, because I think obviously vaginismus is all these systems not working together. Obviously, you need some psychotherapy to relax, but you need also psychotherapy to actually go in because if you need to, apparently the Lavetta-Arnai, the spasm goes away. Okay. And then the Botox also works locally and also centrally. So they does cause peripheral and central sensitization. But all these patients tend to have trauma, previous trauma. So they need a lot of psychiatric and psychological support.
Mm-hmm. Okay.
I think you can understand the importance of this topic, and it stimulates so much discussion and it covers almost every field. And I think unfortunately good things have to come to an end, and I think we are way past our time for ending. And remember, this is not going to be the last we hear of this subject. And I think at this point, we can close the meeting.
Thank you. Thank you. Good
Thank
evening,
you.
everyone.
Thank you very much.
Thank you.
Thank you.
Bye.
Thank you, everyone.